Alright. Hello, everyone. My name is Calvert Tisdale. I am a postdoctoral research fellow at the National Drug and Alcohol Research Centre at UNSW, and I will be chairing the webinar today. Before we start, I would just like to first begin by acknowledging the Bidjigal and Gadigal people as traditional custodians of the land from which I am joining this meeting today. And I'd also like to acknowledge the traditional owners of country throughout Australia, noting that our speakers and audience are joining from many different locations across Australia and potentially internationally as well. I pay my respects to the elders past, present, and emerging, and extend that respect to any First Nations people who are present today in the webinar. Today we have a very exciting presentation from someone who has recently finished their PhD at NDARC, and they will be presenting their immense work today. And I have the pleasure to introduce the speaker on this important topic of optimizing the delivery of substance use interventions for young people in rural communities, Dr. Nicole Snowdon. Dr. Nicole Snowdon is a postdoc who recently, as I said, completed her PhD in March 2024. And her research focuses on implementing and evaluating mental health and substance use programs for marginalised rural Australians in healthcare practice settings. Nicole will also be joined by one of her PhD supervisors, Associate Professor Ryan Courtney. Associate Professor Ryan Courtney is currently a National Heart Foundation Future Leader and was previously an NHMRC Career Development Fellow in Health Behaviour Science at NDARC. His published work includes research on smoking cessation and, in particular, tobacco smoking in low socioeconomic status and disadvantaged populations. His research has a strong focus on the relationships between social disparities, including socioeconomic inequalities and health behaviours and outcomes. Just as a reminder before we start, we will aim to have time for questions at the end, so please send any questions you would like to ask Nicole and Ryan into the Q&A function throughout and following the presentation. I will present these to Nicole and Ryan at the end of the talk, and I may not be able to ask them all, but I will ask as many as possible. So without further ado, I will now invite Nicole to turn on their camera and share their work. Thanks, Nicole.
Thank you, Calvert. And hello, everyone. So I'm coming to you all from Wiradjuri land. It's absolutely beautiful here today in Orange. So a bit about me. So I've got a background in social work, and I've worked in a range of different settings, including medical detoxes with children and with young people. And I was really fortunate to start my thesis back in 2018 at NDARC, and I was awarded earlier this year. And my supervision team was Ryan, Anthony, Jelaine and Kath. And thank you all for getting me over the line with the PhD. Okay, so today I will I'll give you a bit of background about my thesis and what the aims were of my thesis. I'll go over the 4 studies that comprise my thesis and just touch on the future directions that came out of my work. Okay, so firstly, why focus on young people with a substance use concern in rural areas? So in terms of mortality rates, in 2019, across the globe, there were 1.49 million deaths of young people. So half these deaths were due to accidents, violence and self-harm. And substance use was actually a leading contributing factor in these preventable deaths. So young people, they're naturally vulnerable, like especially, given the frontal cortex that's still under development. And for rural young people, the challenges and the risks are heightened with increasing geographical remoteness. There's barriers to healthcare, such as fewer facilities, longer travel times, and limited specialised services. So there's also socioeconomic inequalities in rural areas. And, you know, so all taken together, this means we need timely interventions, and it gives us a really good opportunity to prevent future harms and promote healthier outcomes for young people. So as someone with a social work background, I've always been, you know, really interested in what types of interventions we should be using with people, and also really overwhelmed. So you'll see on this slide here just some of the interventions that can be used with a young person with a substance use concern. So a key thing that I was interested in my thesis was what intervention is best evidenced and how should it be delivered. Another thing to consider is what influences the access and uptake of drug and alcohol services for young people. So when I looked at the literature, it mostly focused on the individualised help-seeking behaviours of young people, like their health literacy, their motivation levels or their lack thereof, heightened distress levels, and preference for self-reliance. There was some research that had been conducted on the delivery setting, and some of the findings indicated that, like, the ease or the difficulty of service use influenced young people accessing services. The perceived level of privacy, the expertise of clinical staff. So that was another thing I wanted to do in my thesis, you know, was looking at what was influencing young people in rural areas accessing services and how can it be improved. Okay, so my thesis aim. So I wanted to look at the best evidence interventions and how rural healthcare services can best deliver them. Yeah. Okay, so to achieve this aim, my thesis was a composite of 4 studies. So there was an overview of systematic reviews to look at the best evidence substance use interventions. In study 2, we examined the factors influencing the delivery of substance use treatment services in rural headspace settings. In study 3, sorry, I'm getting my chapters and my studies confused. In study 3, we conducted an evaluation of a program called the Adolescent Substance Use Program, or ASUP. And that was a program that was aimed at improving workforce capacity to deliver drug and alcohol interventions to young people. And in study 4, we collaborated with key stakeholders to revise ASUP's model of care and realign its aims, activities and measures. Okay, study 1. So, firstly, what is an overview of systematic reviews? So over the past couple of decades, we've seen an increase in individual studies, and systematic reviews give us a chance to summarise really large body of evidence and give us a really strong basis on what type of intervention works and with who. And so in a systematic review, we take similar studies and we analyse them and pull the results and analyse them where possible. So we thought for my thesis that I'd be able to do a systematic review to identify an appropriate model. But when we began reviewing the literature, we found that there'd already been a substantial number of systematic reviews on drug and alcohol interventions for young people in the outpatient setting. And more interestingly, they appeared to conflict on what the most efficacious and or feasible interventions for young people were. So we set about conducting an overview of systematic reviews. And in this method, you follow the same process as a systematic review, and you critically summarise the available evidence of more than one systematic review. And doing it this way gives us a higher level of evidence. Okay, so on to what we did. So over a 6-month period, we reviewed over 7,000 articles for inclusion, and there were 43 systematic reviews meeting our inclusion criteria that have been conducted in the last 30 years. And it was really interesting. There was quite a number of double ups in the systematic reviews. For example, for brief interventions, there were 10 systematic reviews. So after we identified the 43 articles, we extracted the data and assessed the reliability of the methodologies of the systematic reviews using a tool called AmStar2. So what we found that 32 of the reviews were of critically low methodological quality and 6 were of high quality. Okay, so these high quality reviews, the 6 of them, they examined brief strategic family therapy, cognitive behavioural therapy, family behavioural therapy, family functional therapy, multidimensional family therapy, and motivational interviewing. Of these, only one of the systematic reviews said that there was evidence for effectiveness of an intervention, and that intervention was multidimensional family therapy. It's also worthwhile to note that multidimensional family therapy, or MDFT, isn't readily available in Australia, and there's quite high costs involved in training and ongoing accreditation in the program. So we didn't find any high quality studies that examined the implementation of feasibility of interventions. They were mostly focused on effectiveness. So we wanted to look further into the practice setting in the Australian context. Okay. Study number 2. So for those of you who aren't aware, the setting for this study was Headspace centres. So Headspace is a national youth mental health initiative, and it's got over 150 centres in Australia, and they deliver mental health and drug and alcohol interventions to young people. So we know that around 12% of young people in Australia have a substance use concern, but some of the most recently available data from treatment data from Headspace indicated that between 2019 and 2020, only 2% of young people going to Headspace had a substance use concern. And there'd also been some previous results that showed that young people who were presenting to Headspace and they had a substance use concern, they reported the lowest level of satisfaction with the care that they received when compared to other young people with other presenting issues. So we really wanted to look further into this because, you know, there's Headspace centres are so well placed to be supporting young people with a substance use problem. Okay, so for the methods. So we went to 4 rural Headspace centres and we interviewed practitioners, young people, their family, friends, and we conducted 14 focus groups. So primarily asked the questions, how does a young person with an AOD problem get help? What gets in the way of them getting help? And what encourages them to get help? And also what happens at Headspace when the young person has a drug problem? So we transcribed the data and analysed it using an adapted socio-ecological thematic framework. All right. Okay, so you can see on this slide here the analysis we did with using Bronfenbrenner's systems theory. And the barriers and enablers to delivering drug and alcohol interventions in headspace centres were spread out across a few different levels, from the social to the individual. So these really point to clues to how we can better support these services to deliver drug and alcohol interventions. I won't go over all the findings that came out of this study, just a couple that I thought were pertinent for today. So primarily, we found that the youth-focused, non-judgmental focus of headspace centres really emphasised their role in providing AOD interventions for young people. So there was a perception among practitioners that young people didn't want help for their substance use concerns and had a low motivation to get help. But at the same time, we noted that each of the sampled services weren't actively promoting their drug and alcohol intervention services, and there was a lower skill set and confidence between the practitioners to deliver drug and alcohol interventions. So from this, it was clear that some workforce development would be really beneficial in these types of services. Okay, study 3. So we were engaged by a local health district to conduct an evaluation of a newly implemented program that aimed to improve access to substance use service for young people in the LHD region. The program is the Adolescent Substance Use Program, or ASUP. So a bit about the program. So the LHD received $500K per annum continuous funding in 2018 to come up with a program to address youth substance use in the region. They'd found that there'd been quite high levels of substance use comparatively, and a higher level of harms as well. So the LHD conducted some community consultations and they devised ASUP. So the main aim of the program was to install some specialised youth drug and alcohol clinicians to improve workforce capacity within the LHD, as well as deliver some of the pointier end clinical services. In terms of the workforce capacity building component of the program, they aim to do things like conducting service capacity assessments, gaining oversight of all of the incoming drug and alcohol referrals for young people within the LHD, and provide things like training and supervision to other staff. Okay. All right. For anyone that's unfamiliar with program evaluation, this on the slide here just gives you a really basic idea of how and when a program evaluation would happen. So before a program commences, you can conduct a needs assessment to look at where services should be placed. During program implementation, you can conduct an evaluation to see how the program is tracking. And then when the program matures or at its end, you can conduct an evaluation to see the overall effectiveness and its impact. For ASUP, the LHD requested a process evaluation, so that's an evaluation during implementation, to look at if the program was being delivered as planned and the barriers and enablers of implementation. Okay, so we collected a range of service level data and conducted interviews with 14 staff members that were involved in the program, either as implementers or as key stakeholders. Just for the sake of brevity, I won't cover the quantitative data. Instead, I'll just take you through the qualitative data on the barriers and enablers to the program's implementation. So in terms of the qualitative data, we found there was quite a high level of satisfaction with ASUP's clinical services, but there were barriers that primarily related to the workforce development activities, and that's probably was to be expected. And when we drilled down further, the barriers to the workforce development activities were related to some confusion about the overarching aims and deliverables of the program. And such as, like the performance indicators, and, there was also some resourcing restraints as well. So in the evaluation, after the process evaluation, we'd intended to conduct an impact evaluation, but it was clear that we were best served to do some more work on clarifying the program. Okay, so study 4 was about refining ASUP's model of care. To do this, we used a method called the nominal group technique. I'll explain what that is in a sec. Suffice it to say, it's a way to conduct a focus group. So we got together 4 local health district senior staff members and that were directly involved in the implementation and oversight of ASUP. And we asked them about ASUP's overarching aims, activities, and outcomes. Okay, so you'll see here on the slide the process of using nominal group technique, or NGT. So it's really highly structured method of group brainstorming, and it means that you can encourage collaboration and can get to an agreement quickly. Albeit it was a 4-hour workshop, that was, a relatively quick decision-making process. So after you ask your questions, such as what are the problems that ASUP is trying to solve, you can get participants to go through each step, and they write down their responses to the question, they read their responses aloud, so on and so forth, and then you get to the point where you tally all of the ranks, and you have a list of priorities. Okay, so from the NGT process, we were able to really nail down some of those priority issues that ASUP was looking to address, and the activities that and measures to examine the program's effects. After we conducted the workshop, we took the results and we inputted them into it's called a best evidence service improvement, or best program logic model. So this is a model that standardizes programs by their core components and flexible activities. So the core components is what's absolutely necessary for the program to achieve its goals, and the flexible activities are the parts that can be moved around to enact those core components. So what you can see on the slide here is an abridged version of the best program logic, to just give you a feel for what came out of the workshops. So you can see that the workshop participants identified that some of the work that would need to occur was around mapping the specific cohort of young people that needed to be targeted for the ASUP program, revising the workforce planning strategy, and building upon collaboration between services. So there was more to this, but I don't think it would have fit on the screen. All right, so you can see the process that the LHD went through. It fits the plan, do, check, act process. So that's a process that describes, process to influence incremental change. So they developed their model at the planning stage, they enacted it, the doing, and they had an external evaluation, checking, and then they revised the model based on the evaluation act. So the nature of these programs in real life setting means that we need to keep going through these iterative changes and continuously making adjustments. And I think really the benefit of the LHD engaging an external evaluator was that readjustments could be made and a really clear roadmap with measurable outcomes could be developed. And so I expect that the LHD are in the second loop that you can see on the screen there. Okay, all right. To summarise, so in study 1, MDFT was the most promising intervention for treating AOD concerns, but it's not readily available in Australia. In study 2, Headspace centres are a really ideal environment for delivering youth drug and alcohol interventions, but there's barriers to delivery, and meaning that workforce development activities would be really beneficial. In study 3, a program, ASUP, aimed at improving substance use interventions with using workforce development, showed strengths, but it needed some clarification of its aims, activities, and outcome measures. And in study 4, the ASUP program was revised to realign its aims, activities, and positioning it for relaunch and future evaluation and continuous iterative quality improvement. So what does it all mean? So MDFT, it shows the most promise, but it's resource intensive and it's not widely available in Australia. So without a clear and feasible therapy to implement in rural services, we need to think about how to optimise care for young people in rural Australia with a substance use concern. So some of the strategies include, having youth-centric services that are tailored for young people with skilled practitioners that are delivering support, counselling, it's collaborative, empathic. Well, it's not always possible involving families. Young people come from a system, and being able to intervene in that system is likely the most ideal scenario. Encouraging interventions that foster cognitive and behavioural changes as well. And so I think in rural areas, I think LHDs and primary health networks are really well placed to conduct some needs assessments and service mapping, so that when programs are developing their programs, their services, they know where they need to target delivery. Okay, so ideally we can conduct some implementation trials. So a trial of something like MDFT, so we can see how feasible is it and how effective is it in different treatment settings in Australia. Workforce development. We need to make sure that practitioners have all of the resources and skills that they need to support these young people. Another part of it is clear expectation from governing bodies. So having clear expectations that young people with a substance use concern is a key priority, and I think that would really encourage the development of specialised workforce development programs. And finally, embedding evaluation processes. And so when programs are initiated, evaluation is always an aspect of that and an expectation. So I think while MDFT is promising, there's some potential challenges in the Australian context. So a combination of youth-centric services, workforce development, integrated care models, and supported by clear expectations and evaluation processes. So all of those things are needed to optimise care for young people with an AOD concern in rural areas. Okay, so I have been so thankful for the opportunity to do my PhD at MDarg. It's been an incredible journey. So learning about implementation science and healthcare evaluations has been absolutely invaluable. It's really put me in an excellent position in my new role. So I'm currently working as a postdoc at Charles Sturt Uni with Professor Delane Allen. So the work that I'm doing now is focused on implementing mental health and substance use treatment in existing healthcare systems. So you can see up on the slide here the projects that I've been working on. All right. Thank you.
Great. Thank you so much for that engaging and interesting presentation, Nicole. What an impressive body of work that you've completed, and very timely as well, given the obvious need that you've identified within the rural setting, especially among younger people. And I think it's great that you've also aimed on top of that to develop strategies and treatment options, while also looking at how we can best address these issues while also considering the perspectives of the people involved in the treatment process. And also great that you're continuing this work currently. Also, just like to acknowledge how impressive it is that you fit all of that into a relatively short presentation. And I'm sure as a result, there's so many things that were left unsaid, which we'll be able to hopefully address in the Q&A, which I can see already has some questions. Please continue to put the questions there. I was going to invite Associate Professor Ryan Courtney to turn on their camera, but it's already on. Ryan, do you have any immediate reflections that you'd like to share or add to the amazing presentation that Nicole just gave us?
I think me turning on my camera early is just how keen I was to really send. In terms of reflections, I think it's a challenging space that trying to work in particular. I think, as Nicole had said, which was quite surprising to myself as a supervisor, as alongside others, that there's just so few interventions that have been found to be effective. I think by the time a lot of studies were evaluated, or reviews in this instance, that only one was left, and that was at the end had issues with actual implementation and was quite costly. I think, you know, a short presentation in 40 minutes probably doesn't give justice to the amount of work and discussions that, you know, Nicole led, in particular around the project or program logic, and the flexible activities that might go into that. I mean, often we use buzz terms like program logic. There's lots of acronyms that went into this project, but ultimately it was really hard work. It was literally on the cold face. Nicole was going into services, dealing with health professionals, young people affected with substance use problems, and I think by the time the thesis had really developed a framework and an understanding of how to do the co-design as well, and how to develop and build and lead to really good relationships and good outcomes. A lot of the services was very positive with Nicole's work. So yeah, on behalf of the supervisors as well, Nicole, it was an absolute pleasure to supervise you. And as you can see, and everyone can see, that Nicole's now moved on to another program of research that extends on that skill set and expertise that she's had. Yeah.
Thanks, Ryan. And I think that's one of the big challenges, especially in this setting, is how do you effectively implement these programs in potentially resource-poor environments where you may not have resources to create extensive staffing teams, and maybe the program hasn't even been developed yet. So it is very impressive that you were able to work towards that, Nicole. Moving over to the Q&A now, there is a question surrounding the headspaces recruited from study 2, and I'm not sure how much you're able to talk about that, but you may be able to speak towards whether they had co-located specialist AOD practitioners.
Yes, they did. I think now, so that is a core idea for Headspace Services, is that they have co-located drug and alcohol clinicians. In the 4 places that we sampled, I believe that at least one of the drug and alcohol, the external services, the relationship had broken down, possibly even 2, I can't quite remember. So that meant that there was no one going in. In another service, I believe that the feedback was that AOD specialist wasn't an appropriate individual to be delivering services. That was the impression from the Headspace clinicians and management. It's, you know, when we think about it, it's these guys, they're typically adult drug and alcohol workers. So unless you've got a person who is keen to do that work, their primary focus is going to be adult drug and alcohol. I'm sure it's different for other services, you know, the qualitative research is not about generalizability, it's about what was happening in these specific services. So I'm sure it's a model that works really well in other places.
And I think going off of that question, someone else has asked whether there was any lived experience expertise utilized in this study, particularly in order to answer what works. And I guess that can be on either the person delivering the treatment or even on the other side, co-design for the research.
Yes, there was people that had identified with substance use concerns.
And with this, people with lived experience expertise, were they younger people?
Yes.
And did you find that to be more effective?
Yeah. So there were practitioners as well that identified as having a lived experience. So, you know, we didn't co-design anything that wasn't part of, you know, the remit for the thesis. So it was primarily around, you know, what's happening in terms of the services and the organisations. Yeah, that would be the next, you know, next round is doing some of that co-design sort of work.
Yeah, absolutely. Now we're going to focus a little bit more on the measures and methods. Could you talk a little bit about the outcome measures that you in the model? How did you select them? And what do clinicians think about the outcomes and the model as well?
In which model?
I'm not too sure what part of the process Sarah is referring to. Potentially focusing on just maybe what did you measure within your research, and was this chosen with clinicians in mind, the younger people in mind, or what was...
So it might have been where we did the we did the service refinement for the ASUP program, and we got them to, you know, prioritize each of the program aims, the potential activities that address those program aims, and then we also got them to go through the NGT process of ranking and prioritising the outcome measures. So what we did was we got all of that information from those workshops, and we went away and we put them into that program logic that I had up on the screen. And, you know, typically program logics, they will go, well, if it's this type of aim, then that type of activity needs to match that. And then that type of outcome measure needs to match that as well. And it flows like that. And so we did that. We made sure it all matched with that logic. We sent it back to the participants and said, how's this? We did it, you know, and went through, these are the adjustments that we made so that the logic worked. They signed off on it. So that's how it was all selected.
And when you say participants, you're referring to clinicians within the services?
Yeah, the LHD staff.
And you found that they were typically quite agreeable to that
Well, they'd come up with it.
Yeah, yeah, of course.
Yeah.
Ryan, did you have anything to add on that process?
Not in particular, but I mean, I do remember many supervision meetings in documents where the logic was mapped out, and I know it's hard, Nicole, to measure all those outcomes, match those activities, but I can safely say it was dense at one stage, and being able to compact that really well. I think a big thank you probably needed to go to Jelaine as well, who, if I remember right, come up with some good ideas around that as well, and obviously Anthony and others on the supervision team. But yes, you can get caught up in a very big web, Calvert, is what I noticed, and how to unpack it all is quite an art form. And a big thank you to Nicole for doing that, because there was lots of outcomes and activities that needed to be matched. So yeah.
That wasn't all of it. That was I looked at it and went, how can I put this on one slide? This is really hard.
Yeah. It already looked extensive, even as the shortened, less large version.
Yeah.
Focusing on that ASUP, there are a few questions surrounding that. One is from Crystal regarding where they can find more information on the ASUP program, and I would just direct you to please email Ender Communications, and we'll be able to send you through some resources or links, or get you in touch with Nicole as well. And another question around the ASUP focusing on study 3. Was the ASUP originally tracking the output KPIs, or did they just not have KPIs?
So the money come from Ministry of Health, and so I think it was an initiative where they wanted to give buckets of money to a few different LHDs to roll, you know, to address youth substance use. And my understanding was that the KPIs from that level was a little bit fuzzy, wasn't entirely certain what the expectations were. So I think that was, you know, that had a little bit of a flow-on effect. And then, so once it gets to people working on the ground, and, you know, you've got all these competing interests, you can have a little bit of mission creep, and then it's like, oh, but what about these people over here? Oh, this lot of people want this now. And so that can make things incredibly difficult for teams on the ground to deliver programs.
Yeah, and I think there's a lot of potentially invisible things that you have to navigate within, especially when you're given these parameters, and you have to work within that to make everything cohesive. So I imagine that was very difficult to do, but it sounds like you did a great job in navigating.
Oh, look, it's the guys on the ground. It's you know, they're Ryan said I was the coalface. I wasn't at the coalface. I have been, but that, you know, that wasn't. I wasn't. I was just trying to adequately reflect what was happening for people.
I can safely say that there was at least some sort at times on Nicole's face, though, working peripherally and close to the coal face. There's a lot of work that went into the various chapters, but yeah, and as I said earlier, being able to wrangle the different types of health professionals and those with lived experience as well. Yeah, it was challenging, but a really rewarding project.
Yeah, and as I mentioned before, it's so timely. This is a community that is, as you mentioned, Nicole, vulnerable, and these resources would hopefully go a long way. And while it is difficult to navigate these spaces, sometimes someone has to, you know, it's great that you're the one doing it. Going off of that, there is a question from Liam surrounding the LHDs and localized service providers. And while it's practical for them to have the greatest remittent access into youth communities, is there a cohesive collaborative focus on youth-based interventions across these LHD boundaries? Well,
So
I
like,
guess the question is, sorry, Nicole.
No, go ahead.
I think the question is asking whether these LHDs are quite siloed in their approach to youth health service delivery.
That's the impression I get, yeah.
And do you have any insights on how we could potentially approach this to make them more cohesive?
I don't know. Yeah, not today. I don't have any thoughts. I'm sorry.
Yeah, it's a challenge one, Calvert, but just for background, I think, just remind me, Nicole, I think it was all Western New South Wales, so it was quite a large surface area, but
Yeah.
it was a rural/remote area, so it is hard probably for Nicole to reflect on that, because probably didn't necessarily have to intersect with the different LHDs, but yeah, probably couldn't comment on whether or not that experience will be the same elsewhere. But yeah, but there is yeah, as you said, there is potentially some siloing that happens. But I think ultimately, you know, at a state or national level, I think we're all trying to it doesn't matter what area of research we're doing or service delivery, trying to get continuity in care is everything. So yeah, we're
I'm
all
guessing,
trying to
you
get
know,
that.
like, you know, city-based LHDs are quite, you know, they're really close together, and yeah, it's not like that out here. It's only recently doing my new role that I've had any contact with any other LHD. So yeah.
Yeah, it is a massive question. I just thought I'd throw it out there and see if you had an answer. You might have been able to solve all of the rural remote problems in this webinar. Focusing on MDFT, I believe it's the therapy that your review found to be evidence that it was effective. There's a question from Jesse asking where it's been effective, and potentially you could even expand on what that involves.
Oh gosh. Look, it's always in the States, I think. So I think it came out of the United States. It's been used in Canada. Not entirely certain where else it's been used. What it involves, Again, I can't quite remember each of the steps that's involved in the program. What I can say is that what's required for services to be able to implement it is you get trained and accredited as a team. It can't be as an individual. And it's ongoing accreditation every year as a team. And that's where a lot of the costs become involved. I mean, yeah, if you're looking for further information about MDFT, you know, Google is probably the best bet.
Yeah, and also if you once again get into contact with NDART Communications, we can also help you find some resources around the effectiveness of MDFT. Jill has just also added that Queensland has tried it potentially as well.
Yeah, okay.
So that could be an area of further interest for you, Nicole.
Yeah, definitely.
We have one last question from Brett. If you have any other questions, please pop them in the Q&A. But Brett has asked, are the high schools in the rural areas understanding of the issues faced by these young people? And if so, are these schools practicing or including current best practices in an effort to re-engage those young people at risk?
So when I went out and spoke to young people, I distinctly recall a conversation about drug education in high school. And it was probably not the best level of information that young people are getting, and probably focusing on the just say no idea, as opposed to any sort of harm minimization types of strategies. So, you know, personally, that's what I'd like to see. But that's a very political issue. It's extremely political. That was also something that came out in the talking to practitioners in Headspace, was that, you know, while they could go out to schools and do mental health education, they couldn't go out and do drug and alcohol. When a young person came in with a substance use concern, they're not going to want to do harm minimisation with a young person because it's political. There's a lot of stigma around it. So did I answer the question? No, I think I was a bit tangential there. But
I think you answered the question. I think there is still a long way to go with the stigma surrounding the treatment of substance use, and even substance use in general, and how it's viewed in terms of a health issue.
Yeah.
Moving on from that, I actually have a question. I left mine for last this time. You said that there was a perception among clinicians that young people with a substance use concern don't want help. How would you start to address this? And also just adding, maybe young people don't actually see it as a concern at that stage of its progression. So how would you address that when young people potentially aren't reaching out for help?
Yeah, so I guess obviously there may be young people who don't see that they do have an issue. But you know, when I think the cohort that we're talking about are young people who it's they're in trouble. You know, we get to you know, if we're talking teens, we're in trouble if we're heavily using substances. So I would say that there's a little part of them that does want help, that know that there's something going on, and are we offering the right help at the right time? So I think in terms of, I don't think we've got our access to services right. You know, so like for the Headspace stuff, people don't know that it exists, that it's an option, that they could go there if they've got a substance use problem. You know, in terms of clinicians feeling that, well, I can, thinking, well, young people don't want help. You know, if we've got clinicians that, for a number of reasons, and don't have the skills that they need to provide an intervention. You could imagine a situation where a young person comes in, they end up disclosing that there's been substances, involved, and a practitioner could backpedal, could, maybe slip up a little bit in that interaction, and boom, a young person's going to shut down. You really sort of only got one shot in these types of situations, and you want to get it right. So how should it be addressed? Well, I think that's about that workforce development and training and support.
Yeah, and I guess it's also about re-engaging, using opportunities of re-engagement for people that potentially did have a negative experience with a practitioner or social situation, etc.
Yeah.
And this is a pretty big question, but I'm going to pose it anyway. How do you propose to bridge the gap between evidence and practice in the Australian context, and more specifically in the context that you completed your PhD?
Well, I think it's about collaboration and networks. So collaborations between researchers, service providers, end users, people with lived experiences. So doing things like translational activities, implementation trials, I think is really key, and looking at the practice environment, seeing what works and engineering it backwards, practice-based research instead of, evidence-based practice. So trying to close that loop a little bit.
Yeah, and I think obviously it's a massive, far-reaching kind of statement, but I think that's a really good place to end the presentation. Thank you so much, Nicole, for that wonderful presentation and for answering those questions. And thank you so much, Ryan, as well, for making the time to come on and give your insights as well into Nicole's PhD. Before I let everyone go, I will just introduce the webinar for the next week on Thursday, 12th September. That will be focusing on the effect of alcohol policies on domestic, family, and sexual violence in the Northern Territory with Ms. Sarah Clifford. And also just a quick reminder as well about the NDUC Symposium. Registrations will be closing actually on the 9th of September. So that's only 4 days away. So you better hurry and register. And it will be on Friday, the 20th of September in Sydney. So we hope to see you there, and we hope to see you at the next webinar as well. So thank you so much.